Hi everybody, it's Dr. Hall and I'm going to talk to you today about our third lecture on blood, which is mostly about blood groups and transfusions. Before we go ahead and start learning some new material though, I want to spend some time reviewing what we've talked about so far because it's been a while and a lot of things have happened in the interim. So first of all, let's review what we know about blood. So it's a specialized connective tissue. So connective tissues have special cells in some type of an extracellular matrix. And for blood, that is plasma, which serves as a liquid ground substance. So plasma is primarily composed of water. About 90% of it is made of water. And then it also has all kinds of dissolved solutes in it, right? So nutrients like glucose, amino acids, fatty acids, salts or electrolytes like sodium and potassium, minerals like iron and calcium, and then of course hormones, which are relying on the blood to circulate them from one part of the body to another. Finally, then we talked about plasma containing plasma proteins, and we talked about three that are particularly important. The first is fibrinogen, which you'll recall is necessary for forming a clot. So after a blood vessel is damaged and you start bleeding, platelets will be the first on the scene to plug it up, and then fibrinogen will transform into fibrin and create a protein net or mesh that helps to stabilize that clot, trap other blood cells in it, make it stronger, and then eventually pull the torn edges of the blood vessel back together so that it can heal. So fibrinogen is really important in defense against bleeding. Second, we have albumin. So albumin is highly osmotically active. So remember that means that it's going to pull water in and keep water and fluid in the bloodstream inside the blood vessels and prevent them from leaking out into the tissues and causing edema. Finally, we talked about gamma globulins or antibodies, which are generally produced by immune cells, including the B cell lymphocytes. And those are part of our immune system. Those are special proteins, those antibodies that will attack specific foreign invaders, right? So remember, antibodies are part of our specific immune system. They're not general all-comers. So we have plasma, and then we have the formed elements, which are the specialized cells. First among those are going to be the erythrocytes, or red blood cells, whose job is transport, right? So they're going to carry oxygen, and they have a special protein that they're filled with called hemoglobin. And that protein is composed of 4 subunits of protein molecules and 4 subunits of heme molecules. And it's the heme molecules that require iron in order to be produced. So when people say you need to eat more iron, that's so you can make more heme, so you can make more hemoglobin, so that your red blood cells are going to be more optimized for carrying and transporting oxygen. We'll also recall that the red blood cells have a specialized structure. They are that biconcave disc, which increases the amount of surface area. They also have very few organelles inside of them. They don't even have a nucleus. They have sacrificed greatly to just be little sacks of hemoglobin, so you can pack as much hemoglobin inside of them as possible. That biconcave disc not only gives you a lot of surface area, but it also allows those red blood cells to slip through the tiniest of blood vessels, our capillaries. Next, among the formed elements, we have the white blood cells or leukocytes, and we talked about neutrophils, which are also sometimes called polymorphonucleocytes because they have weird-looking nuclei, so polymorphous, many-shaped. And monocytes, which are very large cells, are phagocytic cells. Remember, phagocytosis is where a cell kind of eats another substance, pulls it in, kind of surrounds it, pulls it inside its cell membrane. So they're kind of like Pac-Man cells that roam around and chew up anything that doesn't belong in our bodies. And then we also talked about lymphocytes, of which there are many different types of subtypes, but we talked about how B cells often produce those antibodies that we talked about up under plasma. And T cells some of them are what we call direct killer cells. So they will assassinate other cells that might be infected with a virus, for example. finally, we have platelets, which are sometimes called thrombocytes because thrombus is another word for clot, although they're technically not cells, but rather cell fragments. And what happens is when a blood vessel gets torn or damaged and we start losing blood through the hole in that blood vessel, right? We start bleeding. Then the platelets will be activated by the exposed collagen in that blood vessel wall, and they'll get sticky and they'll plug that opening and kind of plug that hole, and then also set in motion the clotting cascade, including fibrin, to then go ahead and solidify and strengthen the clot over time. So that's a review of the first 2 lectures on blood, and so now we're going to move into talking about blood groups. In order to understand blood groups, we first have to talk about antigens and then again about antibodies. So I've already been talking about antibodies. We're going to talk about them a lot more today. So first of all, I'm going to talk about antigens. And let's see, can I use, okay. So first of all, we have to go way back to the beginning of the semester when we learned about the plasma membrane of cells. So all of our cells have a plasma membrane composed of that phospholipid bilayer, right, with those fatty acid tails on the inside that keeps things that aren't small and nonpolar from being able to pass through. Those plasma membranes have lots of different proteins embedded in them that can serve different functions, right? So up here we have a channel, right? So a transporter, that would be things like the aquaporin that allows water molecules to move through. We also have receptors. So when we talk about hormones, a lot of times a hormone needs a receptor to bind to in order to be able to do its job. But what we're going to talk about today, the type of plasma membrane we're going to talk about today, so I'll change colors here, is antigens. So antigens, as it says here, are cell surface identity markers. So these are like little name tags on the surface of our cell. So you can think of them kind of like luggage tags or name tags that you might stick on if you go to a conference once coronavirus is over and we can have conferences again, right? And they're usually made out of proteins or protein and carbohydrates together called glycoproteins. And they serve like little identifying markers. So for one thing, they tell our immune system, hey, this cell is a part of our body. It's good. This is part of us. All is well, right? As opposed to this is a foreign invader. It also tells our body in many ways what type of cell it is. So these name tags are identifiers, identifying that the cell belongs to your body and also often what type of cell it is. So the immune system is going to look at these antigens. It's going to look at these proteins on the cell surface and say, hey, are you on the list? Are you part of us? And if so, and the phrase we use is self, if the antigens read as self as opposed to non-self or foreign, then our immune system is going to say, okay, you're fine. I'm not going to attack you, right? I'm going to leave you alone. If, however, the immune system looks at the antigen, looks at the name tag, and is like, you are not on the list, you do not belong with us, then the immune system is going to signal alarm. The immune system is going to activate, it's going to start the whole process that it can attack what it sees as a foreign invader, and what usually is a foreign invader. So here's just an image that shows you that if we have, so a pathogen over here, right? A pathogen is a fancy word to mean a germ, right? So a bacteria or a virus, something that doesn't belong in your body. And it's going to have little antigens on it. And if those antigens, because it's a foreign invader, those antigens are going to say non-self, it's going to be foreign, your immune system's going to sound the alarm, and your lymphocytes are going to make antibodies against it. Those antibodies will then bind to the antigens. They're specially designed with their shape to do that, and then mark them as targets for the immune system to destroy. One thing that's really important, I've alluded to this before, is that antibodies are specific to antigens. So if you make an antibody against one type of antigen, that antibody is not going to work against another type of antigen. So here on the left, here is an antibody molecule, antibody protein, and you can see the ends. Antibodies have these weird Y shapes. You can see the ends are customized so that they will bind to these antigens on this cell. So this antibody down here on the left is specific to those antigens on the cell on the upper left. On the right, we have other antibodies with a very different shape that is specific to this shape of this antigen here. So I want to take a moment now to just warn you, because these words are very similar, antigen and antibody, right? So the way I try to remember it is that antigen has a G, like name tag. So the antigen is the protein on the cell surface that serves as an identifier or a name tag. An antibody is the protein that you make against a foreign or non-self antigen. So I think of an antibody as being like a bodyguard, and that's how we remember which one is which. So always take a moment whenever you're reading or thinking about these and make sure you're clear in your head. The antigen is the name tag on the cell surface. An antibody is a protein that you will make to attack an antigen that is not self. All right, so let's talk about erythrocytes and their antigens. So we have two main groups of antigens. There's the ABO group and the RH group. And depending on what antigens you have, that actually determines what your blood type is. So we're going to look at this more closely. Let's focus in on the ABO blood groups first. So in the ABO blood group, what this means is there are two different types of antigens, type A and type B. You can have A antigens on your blood cells, or you can have B antigens on your blood cells, or you can have type A and B, or you can have neither A nor B. So what's really important is that the language that we use to describe these blood types, we use what antigens you have. So if you have A antigens, you have type A. If you have B, you have type B. If you have both A and B, you have type AB, so that all makes sense. And then if you have no antigens, then you have type O. So I always think of type O as almost like type no, right? There are no A or B antigens. This is important because you remember that we'll make antibodies against antigens that are not self, right? I'm not going to make antigens, or excuse me, I'm not going to make antibodies against my own antigens because those are self, but I'm going to make antibodies against antigens that aren't self. So for example, in the first box here on the left, if I have A antigens, then I'm not going to make antibodies against those. But I will make antibodies against type B antigen because those are foreign to me. So if I look in my plasma, I will have anti-B antibodies. Similarly, if you have type B blood, you're not going to make antibodies against B antigen, but you will make antibodies against A antigen because that's foreign to you. So you're going to have anti-A antibody. Interestingly, if you have both, then you're like, hey, it's all good. Everybody's on the list. Everybody's part of my family, right? Both A and B antigens are self. And so you're not going to make antibodies against either A or B. However, if you are type O, right? So this is type O here, then you do not recognize anybody. You're a purist. You don't have any antigens on your blood cells. So you're going to make antibodies against both A and B antigens. Before we move on, I want you to pay attention to the language that we use. When we're describing an antibody, we're going to call it anti-A or anti-B, right? That helps reinforce that these are anti, these are against, these are antibodies that will fight those particular antigens. So this is super important when we're gonna give somebody a transfusion, right? So we haven't yet been able to create synthetic blood. That's really, really tricky. So we are still stuck with having to give people transfusions of other people's blood. And so if we end up giving you blood that you're going to make antibodies against, well, that can be really dangerous, right? So one of the things that can happen is agglutination, where the cells all kind of get clumped together because the antibodies kind of clump them. And the other thing that can happen is hemolysis, where the immune system will actually just destroy the cells and break them open. These reactions can be dangerous and oftentimes even fatal, so we need to make sure that we get this right. So this is just a summary chart, right, of the different blood types showing you what antigens are present on those red blood cells of people with those different blood types, and then what types of antibodies that person would make, right? Remember, you only make antibodies against things that you don't have because you're not going to attack yourself. So there's another group of antigens, which is called RH. So now we need to add this into our ABO blood group. AB no, right? All right, so RH is a different group, and it was first studied in rhesus monkeys, and that's why it has RH, right? Because primates, all of the primates have pretty much the same antigens on our blood cells. And so the thing about the RH is either you have it or you don't. If you have it, then we say you are positive. If you don't have it, then you say you are negative. So in this poorly constructed image here down below, we have an erythrocyte with A antigens on it and RH antigens on it. So this is somebody whose blood type is A positive. If I had an individual with A antigens but no RH antigens, they would be A negative. So just in summary, if you have A positive blood, that means you have both A antigens and RH antigens. So here is a summary that shows you that your blood type is just a way of describing what antigens you have on your red blood cells. So we can see up here, right, this first row, if you have A and you have RH, you're A positive. If you have A and that's it, no RH, you're A negative. If you have B and RH, then you're B positive, and on down the line, right? Keep in mind that O means no A or B, and you can either have RH or not have RH when you are type O. So sometimes it's helpful to just kind of think of this chart when you're trying to determine what types of antigens are present on what blood type of erythrocytes. So RH is interesting because you can make antibodies against RH antigen if you are RH negative, right? So if I'm RH negative and I don't have RH antigen, if I get exposed to that antigen, I'm going to make antibodies against it. Now we always test for transfusion, we always test blood now before giving transfusions, so it's not an issue for that. But there is, however, a situation in which sometimes female-bodied people get exposed, excuse me, to blood that's a different type than theirs. So kind of just think about what that might be. And here comes the reveal. And of course, it's pregnancy. So I'm going to take a little aside, a little journey. We're going to talk about pregnancy and blood. So most of the time during pregnancy, mom's blood and baby, or the fetus before it's born, are completely separate from each other. The blood cells from mom do not go into baby and vice versa. There's an interface at the placenta, which is kind of shown kind of a magnified view here, where the two different types of blood are still separated by a membrane, but it's thin enough and small enough that allows for oxygen and glucose and other nutrients to move from the mom's blood into the fetus's blood, as well as for waste products and carbon dioxide to move from the fetus's blood into the mom's blood, because she can breathe, right? So she's basically breathing for the baby, she's eating for the baby, she's peeing out wastes for the baby, right? Because the baby can't do those things yet. So we have to have this exchange through blood. So most of the time, these nutrients and wastes and gases move across this membrane, and there's no actual mixing of the two different bloodstreams, of mom's bloodstream and baby's bloodstream. However, sometimes if there's some trauma or disruption to the placenta, you can get some tearing, and there can actually be mixing of the two different blood streams, right? So if there's some problems with the placenta during pregnancy, or if someone has a miscarriage, or even during childbirth itself, part of childbirth includes detaching of the placenta, and things can get weird during childbirth, right? So you can get some mixing of the maternal and the fetal bloodstreams occasionally during pregnancy. So now we have to ask ourselves, under what conditions could this be a problem? Under what conditions might the mother make anti-RH antibodies? So first of all, you will only make antibodies against something that you don't have. So therefore, only a mother who is RH negative would ever make antibodies against RH. Secondly, you're only going to make antibodies if you're actually presented with that antigen. So a mother will only make anti-RH antibodies if the fetus has RH antigens. Therefore, only if the fetus is RH positive, right? So the mom has to be RH negative, the baby has to be RH positive, which means in order for the baby to get the RH from somewhere, the biologic father or sperm donor must have been RH positive, right? So sometimes that can be used for paternity tests, but it's pretty rudimentary and will only help you in a few situations. All right. So if this happens, right, if an RH negative mother makes anti-RH antibodies, those antibodies they're small enough, they actually can cross the placenta and get into the baby's bloodstream. Anti-A and anti-B antibodies usually can't cross, but anti-RH antibodies can get into the fetus's bloodstream, right? And they will attack then the baby's red blood cells. And so this can be devastating and cause a condition called hemolytic disease of the newborn, which sounds crazy, but hemolytic, hemolysis, lysis, breaking of the hemoglobin bearing cells, right? So it kind of makes sense, breaking apart the baby's cells. Here's a graphic that kind of shows this potential process. So over on the left here, right, so we have our RH negative woman and an RH positive semen donor. And then if, right, the baby then gets that RH positive, and if there's some disruption of the placenta, then the mother will make antibodies against that RH. That's what those little dark circles are supposed to represent, antibodies. So either later in that pregnancy or in a next pregnancy, right, those antibodies can cross the placenta and affect the baby by attacking its red blood cells. So if this happens, it depends on the situation. Sometimes it just causes some mild anemia. You'll recall that anemia means not having enough red blood cells, right? So if we broke a bunch apart, then you might not have enough of them. Or sometimes it can be really severe. It can be severe enough to cause fetal death, right? Or a miscarriage, even very late in the pregnancy. What we see in this image here is an infant who is born with hemolytic disease of the newborn. So you can see this infant's really small, actually, pretty small for, usually they're not that small when they're born because they're sick, and they're really yellow. And the yellow discoloration, we call that jaundice. And it's because when your red blood cells break apart, hemoglobin gets broken down into a substance called bilirubin, which has this yellowish greenish color to it and cause that jaundiced look. So we want to avoid this if at all possible, right? It can kill the baby or result in significant illness. Jaundice in the infant is associated with a lot of adverse health outcomes. So overall, we know in Rh-negative mothers with Rh-positive babies, the risk of having this disease happen is 16%. However, we have a treatment available, which is amazing, that reduces the risk to less than 0.1%, which is really awesome. That treatment is called RhoGAM. Interestingly, RhoGAM itself is an antibody against Rh. So it's an anti-Rh antibody. And what you do is you give it to the mom when she's pregnant, and then that'll destroy any baby red blood cells that are bearing that Rh antigen that happen to get into the mom's bloodstream before her immune system has a chance to make its own antibodies against them. You might think, but wait a minute, isn't the whole problem to not have anti-Rh antibodies because they can cross the placenta? Well, the antibodies in RhoGAM will not cross the placenta. So this is a nice, safe way to keep the mom's body from becoming what we call sensitized to the Rh, to prevent her own immune system from making anti-Rh antibodies. So now I'm going to change tack a little bit to talk about transfusions and transfusion reactions. And I alluded to this a little bit earlier when we talked about the A and B antigens, or the ABO blood group. And now that we know about Rh, now we have another factor to consider. So it's really important to understand that when we give a blood transfusion to someone who is losing blood because of surgery or a car accident or severe anemia for whatever reason, we don't actually give them what we would call whole blood. We don't give them the red blood cells and the plasma and the white blood cells and the platelets. What we actually do is we separate it off. We separate the platelets off, we separate the plasma off, and we separate the red blood cells off. So when we give a blood transfusion, that's kind of a misnomer. We're really just giving them erythrocytes. We're just giving them the red blood cells. Okay, the plasma is separated and used for other things. So that way, too, we don't need to worry about what antibodies might be in the blood donor's plasma, right? So that is not important when we think about the potential for a transfusion reaction, right? You don't have to worry about the donor's antibodies because we've separated those out. We're not giving those in a transfusion. So the questions we have to consider when figuring out if we can give a transfusion, if a donor's blood is compatible with a recipient, the person who's going to receive the red blood cells, is what antibodies might the recipient have or make? And we know that you'll only make antibodies against things that you don't already have. So depending on what antigens are on the donor's erythrocytes, right? Are they things that are non-self, or are they things that are self, right? Are they things that we would make antibodies against if we're the recipient? So, for example, my blood type happens to be A positive. I know that because I've donated blood a lot. And they tell you, which is kind of fun and neat to know. But so that means I have both A antigens and Rh antigens on my erythrocytes. So A and Rh are totally fine with me. They're cool, they're on the list, they're not a problem. But if I see B antigens, those are non-self, and I would make anti-B antibodies. We don't want to have that happen. So therefore, I can receive any type of blood that doesn't have B, right? As long as it doesn't have B, I'm good with the other two. So I could get A positive, which is what I have, or I could get A negative because that only has A antigens. Those are cool with me. I could get O positive because that means it just has the Rh antigen, which is cool with me. Or I could receive O negative, which has no antigens on it at all. So that's totally fine. So when you think about who you can receive blood from, right, the donor has to have the same or fewer antigens than what the recipient has, right? So I can get blood from somebody who either has the same things that I do or less in terms of the antigens. We look at this from the other perspective. I want to donate blood. So I have A's and I have RHs, right? And I can't give my blood to anybody for whom A or RH are foreign because they will attack them. So I can only donate blood to people who have A and people who have RH. So it turns out there's only two blood types that have A and have RH. And so those would be A positive and AB positive, right? So both of those blood types, they're like, yeah, A is cool with us. Yeah, RH is cool with us, right? They have what I have or more, right? So they are willing to tolerate a wide variety of those antigens. So our first thought question now, who can donate blood to anybody? So I challenge you to pause the recording here and think about it. Whose blood would be acceptable to anybody regardless of their blood type? Take a minute, and then when you're ready, unpause it. So in order to donate blood to anybody and not have them react against it, it must mean you have no antigens whatsoever. You don't have A antigen, you don't have B antigen, and you don't have RH antigen. So if you don't have A or B, you are type O, and if you don't have RH, you are negative. So they must be O negative. So people who are O negative truly can donate their blood to anybody, and so they're also called the universal donor because they can donate blood to anybody. It's universal. It goes around for all people, right? So this is also why if you watch television dramas that are like medical dramas and they're in the emergency room and they're like, I need 2 units of O neg stat, right? So if somebody's coming in a crisis situation and you emergently need to give them a blood transfusion before waiting for the lab to type and cross-match that patient's blood type, you know you can always give O negative blood. You can always give O negative red blood cells. So in an emergency situation, if you have to give a transfusion right away before checking the patient's blood type, you always know you can give O negative. So if you happen to be somebody who has O negative blood, the Red Cross loves you, right? Because we have more demand for that type of blood than anything else because you can donate it to anyone. Thought question number 2, and I forgot to animate it. So the question becomes, who can receive blood from anybody, right? So if you're okay with any antigen, that means you must already have all the antigens, right? Nothing is foreign to you. You've seen it all before. Everybody is on the list. So that means you must have A antigen, you must have B antigen, and you must also have RH antigen. So you've got to be AB positive. People who are AB positive then are called the universal recipient, right? It's all good for them. You can give them whatever blood type you want and they will be fine because everybody's on the list. So AB positive is kind of the exact opposite of O negative. They are the universal recipients. All right, so in summary, antigens are these glycoprotein name tags on cells that serve as identifiers. Antibodies are the bodyguards, the attack proteins that we make against the antigens that are non-self or foreign. So in terms of our blood groups, you can have A, B, AB, or no antigens. If you have neither of those, we call you O. And then with RH, you can have it, in which case you're positive, or not, in which case you're negative. Then we talked about transfusions and how we're just giving the red blood cells, so we care about what antigens are on those red blood cells and how they compare with the antigens that the recipient already has, right? Because I can't give antigens that the recipient doesn't see as self, right? You can't give antigens that are foreign. So the donor's blood has to have either the same antigens or fewer, like O negative, than the recipient's. Or you can think of it as the recipient blood has to have the same antigens or more than the donor's. So that's it for today. I hope that was helpful, and I will be sending you another lecture in short order. Please, if you have questions on this lecture, post them on the discussion board in Canvas, and I will check in there every single day to answer those as they crop up. Thanks so much.